Title: Technical Tips for Endoscopic Ultrasound Guided Embolization of Varices and Pseudoaneurysm. Disclaimer: these are keywords. Disclosure: none. This is a list of equipment used. Endoscopic ultrasound guided vascular intervention has gained worldwide popularity because of its safety profile. Studies have shown that EUS-guided embolization of gastric varices reduces the rebleeding rate, need for reintervention, volume of glue needed, and systemic embolization risk as compared to the conventional gastroscopic glue injection. EUS-guided intervention has also been used for the treatment of pseudoaneurysm, ectopic varices, Dulafy lesion, duodenal ulcer, and tumor bleed. Although EUS-guided embolization has been widely used, there is no standardization of technique. In this review, we will demonstrate techniques of EUS-guided embolization for various lesions. EUS-guided embolization of varices can be achieved by two methods. One by direct puncture of the varix and embolization, and other by feeder vessel embolization. First, we will describe EUS-guided embolization of gastric varices by direct puncture of the varix and embolization technique. Prior to the procedure, IV antibiotic was given to all the patient. Gastroscopy was performed first and it showed large isolated gastric varices with a stigmata of recent bleed. Linear echoendoscope was introduced and varix was located from a G junction on a clockwise rotation, and this varix of size 25 by 12 mm strongly showed a color flow Doppler. So under EUS guidance, the gastric varix was punctured with a 19 gauge FNA needle. The first puncture was made transgastrically. However, on puncture, varix was getting pushed away. So we have changed route to transesophageal, and once the needle was in a varix, coil was loaded. The coil loader has integrated coil within, and this is how it is separated from the assembly. The ex vivo clip demonstrates coil deployment through the FNA needle and the appearance of the coil. Coils have microfibers that help in scaffolding of the glue. All aseptic precautions were taken during the procedure. The coil loader is then attached to the FNA needle, and with needle stellate, coils are loaded within needle. Once coils are in the needle, coil loader is detached from the needle, and with stellate, coils are pushed out of the needle into the varices. Coils appears as a bright hyperechoic rings on EUS. In this patient, two coils of size 035 1414 and 035 1416 were deployed. An ex vivo clip is showing glue preparation. Take an empty sterile 2 ml syringe, fill it with 1 ml glue and remove the air. If lipid oil is being used, take 1 ml of lipid oil in the glue syringe and mix it well for uniform distribution. After each coil deployment, flush the needle with 1 to 2 ml of distilled water. Post coiling, 1 cc glue was injected and 1.5 to 2 ml distilled water was used to flush the glue out of the needle. Post glue injection, needle was withdrawn into the sheath immediately. Sheath was advanced 3 to 4 cm out of the scope, and then whole assembly including scope was taken out of the body. By this way, needle impaction into the varix and scope damage from glue can be prevented. Remove the FNA needle from the scope. Clean the scope transducer with water or acetone. Flush the working channel with a 30 to 40 ml of distilled water followed by burst of air to clear off any glue debris. Perform a similar maneuver for the FNA needle. Scope was introduced again and it showed absence of Doppler flow into the varix. Patient was on a regular follow-up, and at 6-month follow-up, a gastroscopy showed that coils were extruding through the varix, and on EUS, an absence of Doppler flow with hyperechoic rings of coils was observed. Now describing another method of embolizing gastric varix under EUS guidance, that is by blocking feeder vessel. The gastroscopy showed large gastric varices, and on endosono 37 by 29 mm varix with a strong color flow Doppler was seen. On counterclockwise rotation, one feeder vessel was identified and it was traced back and forth till the varix. The technique of EUS-guided feeder vessel embolization is similar to the direct varix embolization. The feeder vessel was identified and it was punctured with a 19 gauge needle, and one coil was deployed, and following that 1 cc glue was injected. Post embolization, an absence of flow was documented within varix. Follow-up gastroscopy at 1 month showed decrease in the size of varix with a tethering of surface mucosa, and on EUS, acoustic shadowing from coil plus glue complex along with the absence of Doppler in the varix as well as feeder vessel was observed. EUS-guided embolization of ectopic duodenal varices. A gastroscopy showed large varices in a duodenum part 3 which were collapsing on insufflation. EUS showed large varix of size 26 by 17 mm with a strong Doppler flow. There were two extramural collaterals seen on both sides of the varix, and they were thought to be one inflow tract and one outflow tract. Under EUS guidance, varix was punctured with a 19 gauge needle and started deploying coils. One coil was deployed, and after deploying that coil, needle was withdrawn gradually and another two coils were deployed. Post coiling, 1 cc glue was injected. Following that, complete thrombosis of varices with a glue complex was seen into the varix, and thrombosis of outflow tract was also noticed on EUS. Post embolization gastroscopy showed non-collapsible varices in D3. Post procedure CT was performed and it showed complete obliteration of the varix with no flow within varix, and artifacts from coils were also seen. Finally, describing EUS-guided embolization of large splenic artery pseudoaneurysm. A gastroscopy showed large bulge in the proximal body of stomach, and on CECT abdomen, vascular lesion enhancing on venous phase rather than arterial phase was seen. So EUS was performed and it showed very large pseudoaneurysm of size 56 by 50 mm in the tail of the pancreas. And on tracing, it was observed that the pseudoaneurysm was arising from the splenic artery. Active oozing from the splenic artery into the pseudoaneurysm was also observed at the splenic hilum. As there was no intervening parenchyma, pseudoaneurysm was directly punctured and multiple coils, almost 8 coils, were deployed. Following coiling, 1 cc glue was injected. Post embolization, absence of oozing seen from the splenic artery on Doppler flow. Absence of Doppler flow was also seen within a pseudoaneurysm, and this is a fluoroscopy image showing multiple coils. Post procedure, CT was performed and it showed no flow within the lesion. EUS after 1 month showed no Doppler flow within pseudoaneurysm and no further oozing from the splenic artery. Finally, to conclude, EUS-guided vascular therapy has excellent outcomes. Proficiency in a EUS-guided embolization is essential to reduce adverse events. Further standardization of the technique is needed to optimize outcomes. Additional studies are required to establish the safety and efficacy of feeder vessel blockage for gastric varices and the treatment of pseudoaneurysm and ectopic varices in comparison to the radiological intervention.